And it is great for us to get to moderate the next session, which is on right-sided lesions. Our first speaker is Greg Johnson. Greg, I think, did medical school at Creighton, if I read correctly.
Yes.
And did fellowship training in pediatric cardiology at Texas Children's, and has been in Austin, Texas for quite a while at the Dell School of Medicine at the University of Texas in Austin. He is the director of the Adult Congenital Heart Disease Center of Central Texas.
All right. Well, thank you. Thank you to Huie and the organizers for inviting me to speak. I have several patients with tetralogy who are in the audience, so we'll see how this goes. Other than being a big soccer fan, I don't have any disclosures. So many of you have heard of tetralogy. It's traditionally described as having 4 lesions. That's how Dr. Fallot described it, with the VSD overriding aorta, narrowing of the right ventricular outflow tract or some form of pulmonary stenosis, and then right ventricular hypertrophy. But physiologically, there are 2 main considerations. That is the VSD and the pulmonary stenosis, or right ventricular outflow tract obstruction. But embryologically, there's just really one defect. Sometimes this is called Tetralogy of Fallot. There is a conal truncal defect with anterior malalignment of the infundibular septum, and then the single embryologic defect results in the main components of tetralogy. This is the most common cyanotic heart defect. It's about 10% of all heart defects. The vast majority of these patients will reach adulthood. It's estimated 94%. The most common, it's in ACHD clinics, it's the most common defect, and it's commonly associated with DiGeorge syndrome. In taking care of these patients, understanding the surgical history of congenital heart disease is important. The surgical therapy for Tetralogy of Fallot has evolved over time. There are different surgical approaches that have specific long-term implications for these patients. The kind of groundbreaking work was classic B2 shunt, which was the first surgical palliation for tetralogy, provided additional pulmonary blood flow. A patient who had this, you may find on exam a lateral thoracotomy and a decreased or absent pulse on the side of the shunt. The long-term implications of this surgery were ventricular volume load, pulmonary vascular disease, and aortic dilatation. Other shunts that were used early on include the POT shunt, which is the descending aorta to the LPA, or a Waterston shunt, the ascending aorta to the RPA. Both of these shunts provide additional blood flow. Both of these are largely no longer used. The implications of these shunts for the long term include pulmonary vascular disease, pulmonary artery distortion, including atresia, and then ventricular volume load and aortic dilatation. In the 1950s, development of bypass allowed for complete repair or an open repair of congenital heart disease. And the first tetralogy repair was in 1954 with VSD closure and relief of right ventricular outflow tract obstruction. That traditionally that repair has been done with a transannular patch and removing the pulmonary valve. During this early stage of congenital heart repair, neonatal and infant repair wasn't available, and so patients for several decades, if they needed some type of palliation, would have a shunt followed later on by surgical repair. Congenital heart disease surgery continued to evolve, and we were able to do surgery in neonates and young infants, and then that provided for primary repair for tetralogy. There was an increased use of pulmonary homographs and bioprosthetic valves as surgery has evolved. And then in recent years, there has been a valve sparing, there's been an emphasis on trying to preserve the pulmonary valve if possible when doing a complete repair. In the adult patient with tetralogy, there's several clinical issues, probably the most important of which is pulmonary regurgitation, but also right ventricular outflow tract obstruction, pulmonary artery stenosis, residual shunts, arrhythmia, ventricular dysfunction. This is a patient who's had a transannular patch. There is some, don't see it in this view, but right ventricular enlargement. You can see a tiny remnant of pulmonary valve right there. And then you have, this is relatively unobstructed right ventricular outflow tract with wide open pulmonary regurgitation, and then the branch pulmonary arteries look pretty good. And then, a parasternal short axis view with a very dilated right ventricle and more normal dimensions of the left ventricle, but because of the pulmonary regurgitation, the right ventricle is significantly enlarged. Because of the type of surgery these patients have had, there's a free PI. This is typically well tolerated in childhood, but as patients progress through life, they will have progressive right ventricular enlargement and will often require a pulmonary valve replacement. There's a wide variability of age when this is necessary. It's sometimes relatively young, sometimes it's several decades in life. The traditional indications for when to replace the pulmonary valve include a indexed right ventricular volume of end-diastolic volume of 150, right ventricular dysfunction, worsening symptoms, decreased performance on exercise testing, ventricular arrhythmias, or a prolonged QRS duration. This was a study that kind of looked at when is at what right ventricular dimensions it would be, should we consider doing pulmonary valve replacement. And you look, each of these lines is an individual patient. That dotted line is kind of what we consider upper limits of normal of right ventricular size, and these were all the various patients and their right ventricular dimensions. All of the patients' right ventricular dimensions got better after pulmonary valve replacement. But if you were larger than 170, then you never got back down to normal. And so that's where this recommendation of starting to think about pulmonary valve replacement at 150 milliliters per meter squared came from. Traditionally, for many years, if we need to replace the pulmonary valve, if there was a transannular patch, we would do that surgically. That has been done with a homograph valve or a cadaver valve. More because of the shortages of cadaver valves, some bioprosthetic valves have been developed in recent decades. They're usually porcine or bovine. Those valves, either variety, may last for 10 to 15 years. More recent development of transcatheter pulmonary valves, which is a bioprosthetic valve supported by a stent and is placed with balloon expansion in the right ventricular outflow tract. This is an option if you've had a previous surgical valve or if there's a right ventricular outflow tract that has a landing zone where you can place the valve. There is work being done to place transcatheter valves in patients with transannular patches where there's wide variability in the shape of the right ventricular outflow tract. and occasionally coronary arteries can run close to the right ventricular outflow tract and can be a limiting factor for placing a transcatheter valve. So this is a gentleman who has had Tetralogy of Fallot repaired as a child, and then had was lost to follow-up for many years. And you'll see he has a markedly dilated right ventricle and right ventricular outflow tract. And we did not feel he was a good surgical candidate, and he had, in addition to wide open pulmonary regurgitation, had stenosis of his proximal branch pulmonary artery. So he not only had obstruction, but wide open pulmonary regurgitation in his with secondary right ventricular enlargement and right ventricular dysfunction. So we used transcatheter valves in the proximal branch pulmonary arteries to address both the obstruction and the regurgitation. One of those. We'll go back. One of those. Can you run that for me? One of those valves leaks a little bit, but he's had good had a good result from that with relief of obstruction and regurgitation, and we've seen some improvement in his right ventricular dimensions and function. Right ventricular outflow tract obstruction needs to be considered for these patients. There can be obstruction at multiple levels. It can be infundibular at the valve or at the valve annulus or supravalvular. Mild obstruction is typically well tolerated. In fact, a lot of the children now who get valve spray and repairs may have a mild degree of obstruction, and we think that that's a good trade-off to have mild obstruction with the benefit of avoiding PI. If there's significant obstruction, they may require intervention. And one option here, as we did with that previous patient, is you may be able to address the obstruction with a transcatheter valve if the issue is combined with regurgitation. Pulmonary artery stenosis needs to be considered. Tetralogy, the lesion at birth may include hypoplastic pulmonary arteries. The pulmonary artery obstruction is also a common sequelae of surgical shunts. We can often address this issue with balloon angioplasty or stent placement. There occasionally is unilateral pulmonary artery atresia related to a shunt and occasional patient with a single lung. We need to consider residual shunts in adult patients. Residual VSD is occasionally seen. Residual surgical shunts, residual BT, POTS, Waterston shunts. They can also have collateral vessels. If there's a significant left to right shunt, this is a left ventricular volume load, and we can sometimes close the surgical shunts in the cath lab. There's sometimes residual atrial shunts. It's possible this was intentional at the time of surgery to improve the operative course. It's a potential source of exertional desaturation, and if it's indicated to close it, that can be done in the cath lab as well. Patients with tetralogy are at risk for Brady tachyarrhythmias. They can have surgical AV block. There was a VSD closure as part of their surgery. Occasional sick sinus syndrome, atrial fibrillation or forms of atrial flutter, and then ventricular tachycardia, fibrillation, and risk of sudden death. Causes of arrhythmias in tetralogy are related to surgical atriotomy and scar or ventriculotomy and scar. The AV node injury, aortic dilatation, atrial stretch, Same thing with the ventricle or ventricular dysfunction. RV hypertension, coronary artery issues. Coronary arteries can be injured during a surgery or with interventions, or systemic hypertension as these patients get into adulthood. The treatment of arrhythmias obviously depends on the issue. I think it's important to try to maintain sinus rhythm or at least an atrial paced rhythm, and to maintain AV synchrony. We generally try to avoid class 1 agents in these patients for their arrhythmias. If somebody presents with arrhythmia, you want to evaluate for any of the hemodynamic issues that we talked about and address those. They may need pacing. There may need to be consideration of defibrillators. Evaluate the coronary arteries. The risk of evaluating the risk of sudden death in patients with tetralogy has evolved. In 2000, there was a longitudinal study that suggested that agent repair and cure restoration was an important factor. In 2008, primarily patients who had defibrillators, the study there suggested that there was that elevated left ventricular end diastolic pressure or non-sustained VT were important considerations. Primarily echo-based study looked at longitudinal strain and mitral annular excursions as a contributing factor to a risk of sudden death. And then more recently, RVH, left ventricular dysfunction, and atrial arrhythmias were thought to be a consideration. This was a list published in 2011 of all the kind of potential contributing factors to risk of sudden death in patients with tetralogy. And then following that, Dr. Valente's study showed that, or appears to show that there are contributing factors from RV hypertrophy, from left ventricular dysfunction, and as you add a factor of the top line, there are no risk factors. This is the freedom from outcome with RV hypertrophy. This adds left ventricular dysfunction, and this line adds atrial arrhythmia. So with each of those seem to be additive. Ventricular dysfunction is an issue with tetralogy. There are multiple causes of right ventricular dysfunction. They often have had a right ventriculotomy. There is chronic pulmonary regurgitation, can be chronic right ventricular alpha tract obstruction. If there's pulmonary artery stenosis, that can result in RV hypertension. Pulmonary hypertension related to their shunts or other causes. Chronic arrhythmia, and again, coronary issues. We need to think about the left ventricle in tetralogy. There are multiple causes of left ventricular dysfunction tetralogy. There may have been volume loading if they had a palliative shunt prior to their complete repair, or if they were a tetralogy that had primarily VSD physiology prior to surgery. They may have ongoing LV volume loading related to residual shunts or aortic valve disease. Aortic regurgitation is fairly common in tetralogy, particularly those patients who had palliative shunts prior to their complete repair. RV dysfunction is an important cause of left ventricular dysfunction, and if you have chronic pulmonary regurgitation, right ventricular enlargement, you have adverse septal interactions between the two ventricles. cardiac surgery, just the fact of having surgery can have an impact on the ventricles. And then later in life, systemic hypertension. And then also we need to think about left ventricular dysfunction in the setting of arrhythmia. If a patient had AV block as part of their surgery and they need to be chronically paced, that can have impacts on left ventricular function, or if there's a chronic atrial arrhythmia. So to address the ventricular dysfunction issues, obviously address the underlying structural and valvular issues, close residual shunts, address the arrhythmias, try to maintain sinus rhythm, or at least atrial pacing if you have intact AV conduction, maintain AV synchrony. If chronic pacing is an issue, consider CRT. Consider either atrial or ventricular ablation if that is indicated. Medications may be indicated depending on the setting. I know there's a later talk on pregnancy, so I won't talk about this too much. Generally well tolerated with tetralogy. The most common complications with tetralogy in pregnancy are right heart failure and arrhythmias. There's an increased risk of congenital heart disease in their offspring. And all patients with tetralogy ought to be screened for DeGeorge syndrome or microdeletion of chromosome 22. To summarize, tetralogy is the most common complex defect seen in ACHD clinics. If they had palliation prior to their complete repair, that's going to have some influence on their long-term course. Probably the most frequent clinical issue is the management of pulmonary regurgitation and the status of their pulmonary valve. Think about the left ventricle. Assess the risk of sudden death. Screen for DeGeorge syndrome. Pregnancy well tolerated. There are evolving surgical and interventional techniques that may alter the clinical course for adult tetralogy patients in the future. So some of the ways we think about tetralogy now may evolve based on how we're trying to do things better when these patients are children. Thank you very much.